As you know, a wrong-sided block may create inconvenience to the patient, with potential for complication from this unnecessary block, such as nerve injury, local anesthetic toxicity of this misplaced injection, or local anesthetic overdose. Also, hospital discharge may be delayed due to reduced mobility. At worst, a wrong-sided nerve block may lead the team to continue to wrong-side surgery. All this will cause a loss of confidence in the care that patient may receive in the future. We all know that there are certain times we need to be more vigilant. The predisposing factors for the wrong-sided nerve block are usually distraction, for example, due to rushing to do the block, or during teaching, or in busy anesthetic room, or due to patient change in position after turning the patient from supine to lateral or to prone position, or if block site was moved, or because of miscommunication. Also, it may be due to the delay between the WHO sign-in and the performance of the nerve block. Also, sometimes covering up the surgical mark with blanket in an attempt to keep the patient warm, or if lower limb nerve block was done and the surgical mark was not immediately visible to the blocker. So, going briefly into the history of the Stop Before You block. Since 2010, a number of safety initiatives have been implemented, focusing on reducing the risk of wrong-side events. These include the Never Event Framework, which was introduced in 2009 and reviewed in 2015. As we know, never events are the serious incidents that are preventable, because we have recommendations that provide strong protective barriers at a national level and should have been implemented by all healthcare providers. The Stop Before You block process used to involve a pause moment just before a block is done to check it is being done correctly. The process is a dual responsibility of the anaesthetist and their assistant. There was always a reminder prompt in place to ensure it is performed. However, despite previous national guidance, Stop Before You block, these errors continue to occur. What was the problem with the original Stop Before You block process? Research revealed misinterpretation of the original Stop Before You block process. While the stop moment should occur immediately before nerve insertion, the stop moment was too often performed at the WHO sign-in to the anesthetic room, which was up to 30 to 45 minutes before block placement. The recommendation that both assistant and anesthetist should check together was usually overlooked. This, along with inconsistent training and varying hospital interpretation, diluted the Stop Before You block effectiveness. It was clear that this misinterpretation of the original Stop Before You block process was confusing for rotating trainees and also made it difficult to map an adverse event against a consistent framework. In 2018, Hobbing et al. Surveyed UK anesthetists, and the important finding was that while most anesthetists believe they perform Stop Before You block, in fact, they perform it at a moment far too early to usually serve as a stop moment. That's why in 2018 there was a request from the Healthcare Safety Investigation Branch for standardization after they investigated the cause of wrong side block and invited the Safe Anesthesia Liaison Group to formulate a standard national policy. There was a need for a simple, standardized process that reduced variation and reliance on memory and vigilance. So in 2021, came this new concept which kept the catchy Stop Before You block title but introduced the PrEP Stop block update. The new approach was presented as an SOP to be applied nationally. While the Stop Before You Block brand was retained, the process of performing the Stop Before You Block moment was deconstructed into 3 steps. As I said earlier, prep, stop, block. And now, any future wrong-sided peripheral nerve block can be investigated and mapped against a common framework. I am sure you all are familiar with this poster of Stop Before You Block in each theater, which demonstrates the 3 steps, the preparation step and the stop and block steps. Step 1, preparation. In this step, patient will arrive to anesthetic room, the anesthetist and the ODP will do the WHO check-in and identify patient identity, check the consent and check the marker, surgical mark on the patient. And then the anesthetist should prepare the local anesthetic drug and place the labeled syringe with suitable block needle into a dedicated tray. And then he should hand over this tray to the ODP. This tray should be out of anesthetist immediate reach. The anesthetist and the ODP should then position the patient and equipment in the final position ready for the block, and the anesthetist will perform the scan. And ideally, the surgical site mark should always be visible during this stage. And during step 2, the stop moment, which should be a 2-person step when the anesthetist will be ready to do the block. He will formally announce that I have completed my preparation and let's stop before you block. The assistant should similarly reply, okay, let's stop before you block. The blocker and the blocker's assistant together should then check the block site by viewing the surgical site mark and verbally confirming the correct site, and the assistant should reconcile this with the consent form, and if the patient is awake, then he may also confirm the site is correct. Step 3, block. Only when the correct site is confirmed does the assistant hand the tray to the blocker. The blocker immediately performs the block, and any delay between handing back the tray or performing the block should require the blocker and the assistant to restart the stop before you block process at step 1. And this should ensure that the blocker will hand back the tray to the assistant. There are some special situations that raise some concerns. For example, in cases where a caster is involved, the tray cannot be handed over due to the sterile field. This requires special vigilance and coordination between the blocker and the assistant to ensure safety and accuracy. And when performing multiple blocks at different sites, it is essential to apply the prep stop block process for each discrete block. This ensures that each block is performed correctly and safely. And for multiple injections at the same site, such as an ankle block, a risk assessment should be performed to determine if one or more stop before you block are necessary. For example, this assessment should consider factors like whether there is any change in the patient position or not. Also, there is some frequently asked questions regarding this in case of multiple surgical site marks for a complex operation, and I will do only one block at one site. What should I do? I need to be more vigilant. I need to communicate this well with my assistant, and I want to make, I want to, we need to be more vigilant during this stage. Also, during teaching, who will be responsible, the blocker or the supervisor? In fact, the supervisor should be responsible and he should be doing the stop before block. However, he should engage also the trainee in this process. Some other questions, like if you need to do the block outside the theater, for example in ER, and there is no surgical site mark and there is no assistant. In that case, you will check the consent, and you will ask someone, the other of the emergency doctor, to do the mark for you, and you should engage an assistant to help you during the process of stop before you block, and that is in order to avoid doing I don't recommend Anaesthetist to do the mark himself, because this can cause some confusion with the surgical mark later, and it can cause some errors. Also, in case of performing a block after surgery where there is no longer any surgical site mark, in that case, the operation site itself will be self-evident and verifiable, and we can ask surgeon to do another mark, and we can ourselves at that stage mark the block site in order to avoid any confusion or any errors. So now I think I have demonstrated that stop before block in its new updates, PrEP stop block, will need engagement from all anesthetic team in order to ensure the safety initiative success. Our role is to ensure staff awareness and to encourage adherence to these national guidelines, and to communicate the PrEP stop block with the entire theater team. By effective implementation, which will require team education by posters in each theater, by running some videos to demonstrate the process of PrEP stop block, by educating our ODBs, and by empowering our team member to speak up to ensure a culture of safety. This is a block tray that I worked on when we tried to launch this PrEP stop block 2 years ago, and it was it was a tool that we used to orient people about the update of the stop before you block, in order to teach everyone about the PrEP stop block, and we can do the same process here if needed. And our rule is to repeat the audit and to ensure that PrEP stop block process is being audited every year, and to engage all members of the anesthetic team, the ODBs and anesthetist trainees, in order to make sure that this safety initiative is implemented. And we can conclude that considerable work is needed to achieve full compliance with stop before you block at the correct time. While no physical intervention can absolutely prevent the wrong site nerve block, I think this well-designed, standardized PrEP stop block approach, used properly by everyone, are the next best thing that we can achieve. Effective implementation will require team education and engagement, and will require empowering all members to speak up and fostering a culture of safety. Thank you.